Hello, this is Stacy Minio here tonight speaking to you on selective dorsal rhizotomy. Cerebral palsy describes a group of permanent disorders of the development of movement and posture causing activity limitations that are attributed to non-progressive disturbances that occurred in the developing fetal or infant brain. Impairments in cerebral palsy include muscle or tendon contractures, bony torsion, hip displacement, cognitive delays, behavioral difficulties, speech impairment, hearing vision limitations, seizures, urinary incontinence, constipation, visual spatial or visual perceptual problems, chronic pain, particularly in the back, and sensory impairments such as 2-point discrimination. Causes of CP are not completely understood. Speculation is given to events in the prenatal, perinatal, or postnatal period. 34% attributed to prenatal period, 43% attributed to the perinatal period, or 6% attributed to postnatal period. There's 16% that's undetermined, and these events were studied by MRI. The events are likely to be ischemic, hypoxic, infectious, congenital, or traumatic in nature, or they have been associated with prematurity, abnormal uterine growth, multiple births, or genetics. The incidence of cerebral palsy is 2.0 to 2.5 per 1,000 live births, 12.6 per 1,000 for twins, and 44.8 per 1,000 for triplets. More prevalent in areas with lower socioeconomics, boys outnumber girls, and newborns weighing less than 2,500 grams account for 50% of cases of cerebral palsy. Cerebral palsy can be classified according to the number of limbs involved. Diplegia is generally both lower limbs have an involvement greater than the upper limbs. Hemiplegia or hemiparesis is an upper and lower limb on one side of the body. Quadriplegia or tetraplegia is involvement of all four limbs. Cerebral palsy can also be classified according to where the lesion is in the brain. Spastic cerebral palsy has involvement in the motor cortex and displays abnormal patterns of posture and reflexes. Dyskinesia is involvement in the basal ganglia, and there are two subsets. Dystonic represents repetitive movements with abnormal postures, or athetoid is represented by writhing movements that interfere with stable posture. A cerebellar lesion demonstrates ataxia, which is characterized by lack of rhythmic coordinated movement, or there could be a mixed presentation. The gross motor functional classification system was developed as a means to objectively classify cerebral palsy rather than use the subjective terms mild, moderate, or severe. Here's a picture of the gross motor functional classification system in children ages 6 to 12. I apologize that the descriptors did not show up quite as well, but we can talk about the pictures. You can see that it goes from level 1 through level 5, level 1 being the least impaired, and level 5 being the most impaired. In level 1, the child is running and is able to walk up and down stairs without support and even carrying an object. In level 2, the child is walking without support but needs to use support when encountering stairs. In level 3, the child can walk using crutches or propel a manual wheelchair. In level 4, the child can walk with a walker or propel using a power chair. And in level 5, the child is dependent. Here is a descriptor of the gross motor functional classification system for cerebral palsy. You can see that it is broken out by ages. So here is the 0 to 2, children between the ages of 2 and 4, between the ages of 4 and 6, and between the ages of 6 and 12, as we just went over. A study by Ross et al. Looked at the relation between muscle weakness and spasticity. Most cases of cerebral palsy demonstrate a degree of spasticity. Decreased muscle strength is evident. Compared with a group without disabilities, the cerebral palsy group demonstrates muscle weakness, and the amount of weakness has no correlation to the amount of spasticity present. Spasticity in children can be treated with physical therapy, bracing, orthopedic surgery, baclofen or Botox, or selective dorsal rhizotomy, which we're going to talk about tonight. So what is this procedure? Well, normal muscles have enough tone for posture and movement. Sensory nerve fibers come from the muscle itself to the spinal cord, relaying feedback from the muscle, including tone. Increased muscle tone is a state where the muscles are always turned on. Children with cerebral palsy exhibit increased muscle tone due to the damage in the brain that affects muscle tone and movement. Selective dorsal rhizotomy exists where some of these rootlets to the spinal cord are cut, thereby decreasing the intensity of the message from the muscles. The surgery itself takes 3 to 4 hours. The surgeon makes a small incision in the low back, cutting above the waist. The surgeon will cut through 1 to 2 vertebrae instead of the 5 to 6 vertebrae as in years past. The surgeon exposes the dorsal roots, leaving the ventral roots intact. The roots are stimulated electrically, and the abnormal ones cut, leaving the normal dorsal roots intact. This procedure is repeated from spinal nerves L1 or L2 through S2. We're going to click on this link here from the St. Louis Children's Hospital where it details the surgery. As you can see, the child is lying prone. The child is hooked up to an EMG machine, and the surgeon makes an incision in the child's waist and stimulates the roots coming out of the spinal cord. Here's a more graphic representation of the surgery. And here is your before and after pictures. And as you can see here, a few of the rootlets were cut, but leaving some intact. After the recovery room, the patient will be in the intensive care unit, bed rest for 3 days in a supine or side-lying position with a turning schedule side to side every 4 to 6 hours. Most patients can move their legs upon waking from anesthesia. After 3 days of bed rest, the patient will be assisted to a chair for 1 hour maximum. Focus is keeping the trunk straight. Upon discharge, the child can sit as tolerated with a stool as a footrest, thereby not allowing the legs to dangle, changing positions frequently, and the child cannot return to school until 3 to 4 weeks post-op. Children quickly resume sitting and crawling. They may take a few weeks to resume walking even if the child was walking before. Intensive post-op physical therapy and home exercise program would be indicated. Surgery can be complicated by paralysis, sensory loss, muscle spasms, abnormal sensitivity on the feet, cerebral spinal fluid leakage, meningitis, weakness of the spine requiring fusion, and in patients with quadriplegia, there can be a recurrence of spasticity. So who is a candidate for this procedure? Most are children ages 2 to 5, but the surgery can be done on older children, adolescents, and adults. It is overwhelmingly for those with spastic diplegia, followed by quadriplegia. It is less likely to be indicated for those with hemiplegia. Most children are walking independently with or without an assistive device. They demonstrate adequate muscle strength in the legs or trunk. They have a history of delayed motor development, but were able to sit, pull the stand, crawl by age 2, but limiting gait by spasticity. They have the motivation and ability to cooperate, and they have the ability to perform intensive physical therapy post-op. Children who are not a candidate for selective dorsal rhizotomy include having a history of head trauma, congenital hydrocephalus unrelated to prematurity, or a history of meningitis. They exhibit mixed cerebral palsy, display rigidity or poor muscle tone. They demonstrate severe scoliosis, and the likelihood of their making functional gains post-op is poor. Outcomes following selective dorsal rhizotomy in a retrospective analysis by Trost, a mean 36% of rootlets were cut. The majority of patients were classified as levels 2 or 3. The outcomes measured were the Gillette Gait Index, Modified Ashworth Scale, the Gross Motor Functional Classification System level, and oxygen expenditure. When looking at gait pathology as measured by the Gillette Gait Index, 7.5 times more likely to have a good outcome versus a poor outcome. Most notable changes in tone occurred in the sagittal plane. 32% of patients no longer needed an assistive device post-op, compared with 3% who did not use a device previously and then needed a device post-op. In a retrospective analysis of the literature by Grunt et al., improvement 5 years following the procedure was not significantly different compared to those who received intensive physical therapy alone. 29% suffer from back pain. However, gait kinematics in hip and knee improved significantly and were maintained for 10 years and 20 years post-op. Step length and cadence resembled temporospatial parameters of the healthy control group 10 years and 20 years post-op. And looking at a study of patients who were 10 years status post selective dorsal rhizotomy surgery, 16 patients out of 19 patients required subsequent orthopedic surgery. The mean number of surgeries per patient was 3, with soft tissue surgery being the most common. Spasticity did remain reduced 10 years post-op. There was a significant increase in gross motor function measure 88 values at 3 years post-op, but then a decline from years 3 through 10 post-op. I would like you all to see this video of this little guy named Carter who underwent the surgery. Here are my references. Thank you for watching.